Hi, everybody. So this is our lecture on asthma. It's covered in chapter 27 of your Neopete's textbook. But if you can reference your Egan's book and your disease book for more information on asthma. So there's several learning objectives that we want to cover here. Again, I think it's just important that you understand the pathophysiology of asthma so you can understand the medications that are required to treat it and manage asthma. Um, uh, it's also important that you guys can kind of understand maintenance and treatments for home and in the hospital with your asthmatic patients. So, asthma is a obstructive disorder that is kind of limits that expiratory airflow. It is considered partially or completely reversible. Either, just on its own, it can kind of spontaneously do that or with treatment. But it is considered a chronic illness. The instances of asthma has increased in the United States. So, uh, asthma counts for many emergency room visits and hospitalizations throughout the country. And it's a main reason for loss of time at school, and that means lost time at work for parents of children that have asthma. So it is kind of considered a health crisis that we want to make sure that we're managing well in this country. Um, so some of the pathogenesis of asthma. Again, it's an immune-mediated process. So what that kind of means is that in a kind of genetically susceptible individually, excuse me, asthma is hereditary, it has an hereditary component. Allergens, respiratory infections, other exposures can stimulate uh, airway inflammation, bronchial hypersensitivity, and hypersecretions of mucus. Okay. So there's kind of 6 significant components of the airway obstruction in asthma. One of them is being that initial inflammation. Then usually when we're dealing with exacerbations, there's going to be that acute bronchoconstriction. Airway edema can be present, mucus plugging, that hyper-responsiveness, or that the airways that get easily irritated and having that smooth muscle contraction. And finally, if this happens enough, you can have some airway remodeling taking place, meaning that the airway is permanently changed and it becomes not reversible and can lead to like COPD later in life. So these obstructions then lead to difficulty getting air in, gas trapping, atelectasis from mucus plugging, ventilation perfusion abnormalities, usually related to hypoxemia, fatigue, and hypercarbia. So usually when we're talking about risk factors with kids, usually it's that allergic response um, to um, to allergens that cause like a specific immunoglobulin E molecules. These will attach to like mast cells in the mucosa, in the bronchioles, and those mast cells will usually degranulate rapidly. So that means that they're going to release things like leukotrienes, histamine, prostaglandins, and other mediators, which causes that smooth muscle contraction, a lot of congestion, vascular congestion, so edema, leakage, again, resulting in edema and that airflow obstruction. Okay, so that is your 8 atopy or atopy is a term that we use for individuals who have like an abnormal immune response, where your immune system is more sensitive uh, to those allergens. Um, atopic dermatitis is also usually referred to as like eczema. This is why eczema, allergies, asthma are all kind of go hand in hand. We see these all in the same types of patient populations. Um, Again, because they're more sensitive, they have a more hyperactive immune system. These kids with asthma also can have a lot of food sensitivities as well. You can also have patients that just have a non-allergic asthma, so they have like environmental triggers, which is tobacco smoke is a main one, cockroach antigens, molds, dust mites, things like that. So, because we mentioned that this is kind of a big problem in the country, big health crisis in the country, the government put together a national asthma education or prevention program. This is to promote not only asthma education to the public, but educating health professionals by giving them like guidelines and standards for care, and then education for specific education for our patients. So again, this is just like the GOLDLA guidelines. The recommendations are all evidence-based. I think the first report was published in 2007. And again, it's for that diagnosis and management of asthma. So when you're looking at diagnosis, it usually kind of requires a two-pronged approach of clinical assessment and also supported by evaluation with like lab data and maybe pulmonary function testing. So there's no single measurement that really can absolutely establish a diagnosis. They do that physical exam, could be entirely normal, but getting a medical history of this recurring wheezing, chest tightness, shortness of breath, coughing, difficulty sleeping or staying asleep, can kind of make us assume that the patient is struggling with asthma. Again, like I said, the physical assessment can appear normal because if they're not in an acute exacerbation, they're not really having symptoms or complications with their asthma. They should be ordered on some pulmonary function testing. We just learned all about pulmonary function testing. To confirm the diagnosis of asthma, usually you need to demonstrate that reversible airflow limitation. So PFTs can be normal in an asymptomatic patient, or you could see that decreased FEV1 FVC ratio. So typically you want to do a pre-post bronchodilator. A 12% change will indicate that reversibility. And if it's not demonstrated on that, again, we're looking at a bronchial challenge or bronchial provocation test, or methacholine challenge they talk about, or an exercise test to elicit that bronchospasm. And again, you're going to do a differential diagnosis to rule out other possible causes. Another laboratory data that they might tests that they might do for these types of patients is they might decide to do some blood work and look for that elevated IgE levels and eosinophilia. Okay, so this is, if those are present, it doesn't necessarily mean that it is asthma. If they're not present, you can't exclude asthma. But if you do have those elevated IgE levels, that can kind of tailor or alter your treatment choices, because again, these are the types of patients that need those mast cell inhibitors and leukotriene inhibitors to help effectively manage their asthma. Okay. So for management of asthma, we are looking at pharmacological therapy, so long-term medications. Typically, when you're looking at the stepwise approach to asthma, you're looking at starting with inhaled corticosteroids to treat the inflammation, then moving on to adding a LABA. You can also consider adding methylxanthines, leukotriene inhibitors, immunomodulators are your Xolaires. That's like the shot they take every month. Again, that's for these last two specifically are for those patients that have elevated IgE levels, are usually for these two last ones. Methylxanthines are your theophylline that can increase your diaphragmatic contraction and help with work of breathing, stimulates respiration. So that's what those are used for. For quick relief medications, we're always going to start with Asaba as needed. Anticholinergic agents are only added if your first dose of albuterol is ineffective, and then you want to add those systemic corticosteroids like your prednisone, methylprednisone, things like that. You want to make sure that as a respiratory therapist, you're recommending the appropriate delivery system. MDIs are in a patient who can effectively take the MDI is equally as effective as a nebulizer. So don't discount giving, if your only SABA choice is a 2 puffs of albuterol MDI, then that is the acceptable choice. There's nothing wrong with giving an MDI to a patient in an asthma attack as long as they can follow commands and have the coordination to take the MDI properly. If they don't, that's when we need to recommend the small volume nebulizer. There is not any evidence that states that continuous nebs are better than small volume nebs for your albuterol delivery. So you can give a continuous neb, or you can give the albuterol unit dose up to 3 doses every 20 minutes. For your continuous neb, anywhere from 10 to 15 milligrams of albuterol is the recommended dose. Okay. So most children have the allergic component of their disease, so we need to control their asthma triggers. So identify what they're allergic to, make sure that we're educating our parents for avoidance and control measures, and the role of that immunotherapy, that Xolair medications. They just kind of block or moderate the release of those antigens, so it helps with that inflammatory response. So typically those are only going to be indicated for patients who have tried and failed ICSs, leukotriene inhibitors, mast cell inhibitors, all the other things. So typically it's step 5 or 6 when you're going to start recommending your Xolair. Usually that has to do with the cost. It's a lot more expensive than some of these other medication routes. So insurance wants to show that the patient cannot be managed on more, fiscally conservative therapies. Okay. It's also important when we're talking about management of asthma to be recommending daily peak flows and monitoring those in your peak flow diary. So this is going to help us establish that personal best reading. Also, that helps us with monitoring our patients. If they're doing it daily, they can identify sometimes when they're kind of getting into that initial inflammatory stage and their peak flows are kind of dropping into below 80% of predicted, but still above 50% of their predicted. That 50 to 80% of predicted range, that's kind of considered that yellow zone and may indicate that they might need to increase their steroid dosage, or, seek physician consultation so that they can hopefully avoid ending up in the red zone, that less than 50% of predicted, and in the emergency room. uh, Having an asthma action plan. This plan kind of helps kind of organize things for patients at home so that they understand what they're supposed to be doing to control their asthma on their good days, and then how to increase their therapy appropriately when they're having, shortness of breath, and some of their asthma symptoms. So it's going to be based on that current peak flow reading versus their personal best. Obviously begin with those quick relief medications as you run into more problems. Maybe increase your dosage on some of your ICS medications. Contacting physician and seeking that emergency care are all appropriate steps for your asthma action plan. Oops, sorry. Okay, so in the ED, when you're dealing with a patient with an asthma exacerbation, we want to perform that physical examination. So always low-hanging fruit again, you guys. Make sure you do a thorough physical exam, getting vital signs, doing a chest assessment, which includes auscultation, percussion, lung expansion, getting those measurements of an SpO2, and that airflow by getting at peak flow reading. So PFR, that peak flow rate, you're going to want is always something that's appropriate to do in the emergency room. Okay, so again, we're going to then start treatment with beta agonists. That means albuterol or levalbuterol. You're going to give 3 treatments every 20 to 30 minutes, unit dose. Again, MDIs are appropriate as well, as long as the patient can effectively take them. Then moving on to your corticosteroid therapy. This early treatment includes that IV corticosteroids, meaning prednisone, methylprednisone, or oral prednisone. If the patient has any signs of respiratory failure, we want to, intubate. We want to make our recommendation to intubate before they completely crash on us. So when we identify those signs of impending respiratory failure, that increased respiratory rate, respiratory rates above 30 to 35 usually indicate that we're going into failure. Increased worker breathing. When you place them on mechanical ventilator, again, you're starting in our normal tidal volume ranges of 6 to 8 milliliters per kilogram. We're going to use low to moderate PEEP. Again, the patient's already auto PEEPing a lot, so we don't want to put a lot more PEEP on top of that. And then you want to potentially allow for permissive hypercapnia to avoid further gas trapping. Remember, the asthma is an obstructive disease, so our airway resistance is our problem. So we need to use low flow rates to try to give yourself some time to get the air in, get air back out for your asthmatic type patients. Exercise-induced bronchospasm. This is, common in children athletes. So this usually means that you're going to have this bronchospasm 5 to 10 minutes after that activity at its worst. So it might go away on its own. It can be helpful to hyperventilate cool, dry air to try to help that hypersensitivity. These patients are good, usually treated with beta agonists. Chromium sodium usually is a good medication for exercise-induced bronchospasm because it's a mast cell inhibitor. So does nitrocromulin. Salmeterol is a LABA. Um, so typically they recommend doing, taking these things before exercise, making sure you're warming up properly. So typically what we do with kids that have exercise-induced asthma is maybe tell them, hey, take your albuterol inhaler about 15 minutes before you're supposed to go to gym class or whatever to try to help with the symptoms. Cromulin, sodium, remember that one, or Intel, I think is the other brand name. That medication is never helpful in the acute phase. So typically those patients have to be on it. It's a maintenance medication. They have to be on it for at least 2 weeks for it to do any good. So you're never going to order that in an acute situation. I already mentioned this. Asthma is a leading cause of absenteeism in the schools. If you know somebody who has asthma or a child with asthma, you might realize that, they end up having to miss a lot of days of school because when it's not controlled. Because they're not at school, that leads to poor academic achievement, can also affect kids' self-esteem. Because they're not in school, they're not participating the way their friends do. They kind of feel like they're a little bit of an outsider. So that's why there's such a big push to try to help manage asthma and control it, because asthma can be well controlled. We just need to if we get you on the right treatment regimen. Asthma camps also, this is a great opportunity for you guys. After you guys graduate, they have many asthma camps around the country. There's one in Wisconsin that's always looking for volunteers to go out and help kids, teach kids about recognizing their symptoms, how to respond, helping put together those asthma action plans, helping kids, kind of feel like they have like a normal childhood existence even with this chronic condition. So all right, so that is it for asthma. Again, I think you can assume that you're going to get several questions potentially on the MBRC exam related to either COPD or asthma and which medications to pick when for control. So I think writing out that algorithm of which medications I'm doing on in which order for my patients is important. So I think this medication slide is kind of important for you guys to understand. So, oops, I don't know why this is not letting me do what I want it to do. Okay, so this one. So again, making sure that we know what our long-term controller medications are. So again, we're always starting our patient with a SABA PRN. So this is PRN. Then we're going to go to an ICS. Then we're going to go to either increasing our ICS dosing, because remember your ICSs have different dosages. So you're starting with a low dose here, and you can increase to a moderate dose here, or you're going to add your LABA in this level. Okay. And then you're going to add your the next level. This is where you do your combination. ICS LABA, that's like your Advair's. You can also increase your dose of your ICS to a high dose ICS. Ooh, I'm running out of room. And then after this stage, so we're at stage 1, 2, 3, 4. After this stage, this is where you're going to start thinking about adding those IgE modulators, Xolair, things like that. So after this stage, by the 5th stage, you're going to be on those patients are on a high dose ICS. They're on a LABA. We might want to consider adding those Ig inhibitors, modulators. Step 6, that's usually when we're adding those oral corticosteroids as well, because those patients are really out of control. Obviously, there's a lot of systemic issues with doing oral corticosteroids, so we want to make sure that we avoid that as much as possible. All right, that is it. If you have any questions, please let me know.